Common musculoskeletal conditions. The musculoskeletal complaint is something that we need to have a standardized, often sequential procedure in order to identify what is going on so the doctor can identify what they can manage or not manage. In the decision-making process, we need to rule in or out referable conditions. And with this, we need to be able to identify if there are any red flags present. With acute traumatic pain, we need to be concerned about fracture, dislocation, gross instabilities. With non-traumatic pain, things such as tumors, inflammatory arthritides, infections, or some viscerogenic pain needs to be considered during the initial decision-making process. Errors that occur in the management is that all joints are different due to their names of structures, disorders, or the orthopedic tests associated with them, and that joints act independently of other joints. But the reality is that joints are very similar. They have the same configuration, and they act dependent along the kinetic chain. So some of the things that we need to be concerned about are the fact that all joints are composed of basically the same tissue, although in different configurations. We need to take the general approach that a joint is a joint. It may function differently, but structurally is composed of the same tissue. We do need to be concerned about forces that can act upon this joint, whether it's compression or stretch, will lead us to different types of diagnostic processes we need to be concerned about. Weight-bearing joints are also more susceptible to degenerative changes, but non-weight-bearing joints can be susceptible to degenerative changes, such as wrist joints in a gymnast or in a wrestler. Sometimes if they put too much force on the cervical dorsal junction, they can start to have early degenerative changes later on in life. So we also need to be concerned about non-mechanical processes, infection, cancer, immunological processes. So the first thing we need to identify is the pain generator. When a patient comes in with a complaint, we need to identify which of the following structures may be involved, if it's muscle, tendon, ligament, bursa, joint, etc. If we're unable to identify what is generating that pain, we are left with the potential of something more sinister, such as a viscerogenic referred pain pattern or something going on with the bone itself. The quality of pain is something we also need to be concerned about, and this list identifies the different types of descriptions and what it may lead you to identify in terms of what anatomical structures. This chart does not need to be memorized, but it is good to have an idea of what certain descriptions can indicate in terms of what structures are involved. Now, when we talk about common somatic conditions, we need to be concerned about muscles, whether there's a strain or a rupture, whether there's a problem with the muscle itself in something that we see with fibromyalgia or myofascial pain. I'm going to refer you to the PowerPoint on muscular conditions that is going to be presented in lecture to go into more detail about these types of conditions. Other things we need to be concerned about: tendons, that they're susceptible to overstrain due to fall, overuse. Tendinitis tends to be more chronic than it tends to be acute, although you can have acute tendon issues. You can have ruptures of tendons where tendinitis itself tends to be more chronic. Pain is more noted with active range of motion, especially when we have contraction of the muscle belly associated with it, such as what we see with bicipital tendinitis. Now, bursae tend to be more chronically induced. So we tend to see bursitis more of a chronic issue, although once again you can have acute traumatic bursitis, but it is not as common. Ligamentous involvement also is dealt with when we're dealing with gross instability or dislocations, and we need to be able to identify whether it's a valgus or varus stress that is putting force upon that ligament. When there is no obvious mechanical or traumatic causes, that's when we need to be considering infection, tumor, metabolic disorders. The Review of Systems PowerPoint on Blackboard helps identify some of these other items that we need to be thinking about. When we talk about the joint itself, we can have arthritis or subluxation, needing to understand the difference between the chiropractic definition of subluxation and the medical definition. In Souza, he refers to the medical definition quite often, but understanding that that is a near dislocation, where chiropractic subluxation is more neuroarticular dysfunction, which you should already be well versed in. We also need to look at the bone. Is there a problem? Could we have a tumor, a fracture, some sort of infection, some bone loss, things that are going to lead to some pathological processes associated with this? Now, when we talk about doing orthopedic tests in relation to somatic conditions, one of the main reasons is we need to reproduce the patient's complaint. If you perform an exam and you are not able to reproduce the patient's complaint through the physical examination, there are one of two things that is going on. One, the patient has some sort of referred pain, or two, you did not do the test proficiently enough. These are things that we're going to be working on in lab to get you to be able to perform the tests so that clinical data could be obtained. Other things with orthopedic tests, we need to demonstrate if there's weakness or restriction. Remembering the intent of the test. Some tests look very similar to some other tests. For example, the muscle test for the C6 nerve root looks very similar to Cosen's, remembering the intent. With Cosen's, we're looking for pain at the lateral epicondyle, indicating some sort of tendinitis. Now, with the C6 muscle test, we're actually looking for true neurological weakness. If the patient demonstrates pain with forced wrist extension at the elbow, we need to consider that that is bringing on some other underlying pathological issue that we did not expect. Now, when we talk about pain referral patterns, there's sclerotogenous, myotogenous, dermatogenous, and viscerogenic. When we look at the somite consists of 3 separate layers. Each of these brought forth different types of tissue. And as the tissue was formed and the limb buds formed and it dragged tissue with it, we will see these differing patterns, and that's why dermatonal patterns tend to have rotational components to it, and it is not just a straight line. So when sclerotogenous pain, this is pain derived from connective tissue. In the spine, it is synonymous with pain from the facet joint. It's usually dull, achy, nondescript. Patient has difficulty describing it. It does not follow dermatonal patterns or peripheral nerve patterns. In the cervical spine, it doesn't cross the glenohumeral joint, and the lumbar spine, it tends not to cross mid-thigh or beyond the knee. Pain at the site of the origin may be very sharp when we think of facet, but it's that dull, achy, referred pain that we're describing as the sclerotogenous component of it. Dermatogenous pain you should be well versed on. It's pain derived from a nerve root. Understanding it is dermatonal pain, it's radicular in nature. Remember the terms radicular indicates nerve root. Radiating just means it's traveling from the spine. They are not interchangeable terms. Though radicular pain is radiating in nature, radiating pain is not always radicular. With dermatogenous pain, the patient can generally pinpoint exactly where the pain is, unlike that with sclerotogenous pain. The pain tends to be sharp or shooting, but it does not have to be in order to be dermatogenous pain. It's just pain along the dermatonal area. Getting back into terminology, talking about radiculopathy, it's pathology of the nerve root. Neuropathy is just pathology of any nerve. So diabetic neuropathy is an example of a metabolic neuropathy, where median neuropathy is an example of a compressive neuropathy. Please make sure you understand the difference in these terminologies, and understanding that peripheral nerves can never be radicular in nature because radicular indicates it's coming from the nerve root. Now, when we talk about myotogenous pain, that is pain derived from the muscle. There's a separate PowerPoint, as I noted earlier, on Blackboard that describes the difference between myofascial pain and fibromyalgia. Now, viscerogenic pain is pain derived from visceral organs. We will be covering this specifically next week when we talk about the viscerogenic pain patterns. But the pain may be sharp at the site of the origin, but the referred pain is usually dull, achy, and nondescript. Most viscerogenic pain begins midline in nature and then will eventually radiate to the origin of the site. For example, a patient with appendicitis will have epigastric or periumbilical pain to begin with, and then will eventually end up with the right lower quadrant excruciating pain that we typically see with this.